Hello and welcome. Thank you for joining me on this episode today. We've got a huge episode packed with a lot of content and a lot of knowledge from Brad Hiskins. He's a soft tissue therapist with over 30 years experience. He spent 11 years as a soft tissue therapist at the Australian Institute of Sport. He's been involved in 5 Olympic Games campaigns. 2 of those he was head of service, and 2 Commonwealth Games in both which he was head of service. He has presented at numerous conferences nationally and internationally. He's the director of Clinic 88 in Canberra, so he has a lot of knowledge and experience, and I'm really looking forward to today's episode. Let's get started. Well, thank you so much for joining us. I'm joined today by Brad Hiskins. He's a soft tissue therapist with over 30 years experience. Brad, you were my teacher back in the day, or one of them, and also my boss at Clinic 88. So I've been fortunate enough to learn a lot from you over the years. So thank you so much for joining us today.
Thank you, mate. It's a pleasure. I hope I've done a reasonable job with you. You look like you're going okay.
Getting there.
And you guys, like this isn't my hair. I just thought I'm going out with all those people that have been in lockdown for a little while, and there's no hairdressing, so I'm as balls of back.
I was going to say, I know it's been a while since I've seen you, but there's the chrome dome. It's back. So today we want to talk about all things myotherapy related. So I know you've got so much clinical experience and knowledge, and we could spend hours talking about all things clinic, but is there anything today that has come across your interest in clinical practice recently?
Yeah, absolutely. As you remember, I'm a bit of a nerd, mate. I can't help but keep looking for new stuff and trying to make sense of what we see in the clinic. And when we had a little bit of a chat about what I could potentially talk about, I was really interested in talking about the asymmetry of the spine. And I know that's been a little bit of a hot topic for a while and for quite some time. So I thought I would pass on some of the knowledge that I've gained over the last few years and a lot of the research that I've read, which I really wish I had known 30 years ago, mate, because it would have made things a whole lot easier. So yeah, the asymmetry of the spine.
Yeah, and that is an interesting topic, isn't it? Because there's certainly so many arguments for and against. So I'm sure you'll be able to shed some more light on this topic.
Yeah, absolutely, mate. I mean, there's no such thing as symmetry. It's kind of silly. You only have to look at our organs. There's no symmetry there. You love the old one. I've been told I've got a long leg. I'd be absolutely surprised beyond belief if someone had the same length legs. I mean, it's just silly to think that we can produce ourselves to a point where we're symmetrical. So there's no such thing as symmetry. I mean, we're all asymmetrical. And I think the important part to remember is that as we grow, our bones grow, that our muscles and tendons and ligaments and joints and so on will adapt to that load as we grow. And I think where that becomes a bit of an issue is in modern day society. So if we're out chasing deer and digging up yams, it doesn't really matter too much because you're constantly loading things, the axial plane, the rotational plane, all the different planes in all different ways constantly. So you're not overloading something all the time. However, modern day society, when we're in, I call it a 1990 world, where, for instance, I'm sitting in front of this computer right now, and I'm basically trying to be 1990 to this computer. Well, a lot of us have a natural rotation to the right of our cervical spine. So why don't we just move the computer 7 degrees to the right, where most of our heads sit, rather than trying to force going to the left, as an example. Or when we're in the gym and we put our feet on a line and put 50, 60 kilograms above our head, and we try to do everything symmetrical when our bodies just aren't symmetrical. So I think in those situations, we potentially start making areas of our body vulnerable because they are not supposed to be loaded in the same way at the same time because of the structural abnormalities that we have.
Yeah. Well, that's really interesting the way you put it like that, because I think there's this idea that we do need to be square, and the way that we move has to be in a specific plane, and anything that's outside of that, we sort of get these alarm bells of, oh no, we need to fix it or we need to change it. But what you're saying is we need to adapt to that position. Is that correct?
Well, not even adapt, because our bodies have already adapted.
We're already there, yeah.
As we grow, we adapt to our environment. It's only when we put ourselves in the stupid positions that we put ourselves in, like sport. Like if you're generally just running, then we're moving through all the different planes, loading structures different, I guess, to a point. But then you get yourself into a stuck position like rowing. So you do have a true leg length discrepancy, let's say a centimetre as an argument's sake. Then you've got both feet strapped into a position where all of a sudden that leg length discrepancy can start creating some rotations and excessive force on one side versus the other. So I think the environments that we put ourselves in can exacerbate those normal asymmetries we have. There's other sports where you can play until you're 50 and not get injured, like basketball, because you're constantly moving in all these different planes, loading different structures. I think those sports, those hobbies, those environments are okay. It's only when we stick ourselves in these like the gym base would be the classic one, because everything is built 90-90, you know. So when we try to put ourselves in those environments, then I think the adaptation process needs to occur. Otherwise, you're not going to have the performance you want or stay uninjured. So I think it's those environments where you think, well, I'm going to put myself in this 90-90 world, I have to be in it. So I'm going to have to adjust slowly rather than try to do it abruptly. I think those abrupt changes and loading is where we start to get injuries.
Yeah, right. So as a general population, that we're not tend to be doing that high level cyclical loading like in rowing, but we tend to sit in positions for extended periods of time and then potentially go to the gym and do bilateral work that overhead that may lead to some of these pain presentations.
Yeah, and I mean, look at farmers. Farmers don't get this sort of stuff. They're constantly doing it all day long. They've been loading themselves since they were kids, but you get people sitting behind a desk for 45 hours a week. You get in a car, drive home, sit on the couch for 5 hours. But then on Thursday afternoon decide to go to the gym and smash out an hour and a half session. So those people are probably the most vulnerable ones because they're not loading themselves on a regular basis, daily basis, hourly basis. Plus, if they do have asymmetries more than what the average person does, which we'll get to in a minute, which is the crux of the discussion today, then I think those people become a little bit more vulnerable. So if you've got someone, let's say, that's got larger asymmetries than another person, plus that person tends to be a little bit of a floppy, so they've got more hypermobility, you chuck that combination in the gym, then yeah, look, you just don't have the ligamentous or fascial connective tissue stiffness there to protect you, plus you've got these asymmetries which might load one facet more than the other with, say, bilateral movements. I think those people are even more vulnerable than others.
Yeah, so we have to consider those genetic and lifestyle factors in combination with physical activity.
Absolutely. So when I'm assessing someone, for instance, someone comes in and says, I have X going wrong, which is whether it be a dysfunction or I want more performance out of myself, or when I'm at the gym I'm getting injured, that I have to consider all that stuff. Are they hypermobile? Do they have, everyone's got an asymmetry, but how much of an asymmetry is it? How much within that asymmetry are they moving? Just because they're asymmetrical, they still might be able to move equally both ways, but sometimes you get an asymmetry and they move really well one way and not at all the other. So you still have to address or consider and address all those things. And yeah, lifestyle loading. You're sitting at a desk all week long, not doing anything. Jump in a gym, load yourself aggressively, then yeah, you become more vulnerable. So that will all, there are lots of boxes to be considered and ticked when you're setting yourself a protocol for like a treatment protocol.
That's great, because when someone comes in, we do need to consider all aspects and not just simply look at the posture and say that the posture is the reason for it.
No,
there's so much more to it.
I've got for the juniors at the clinic, we've got a tick the box protocol where if someone's assessing someone getting a bit lost is that to back up, check the box ticking exercise. There's about 12 boxes there, and it goes through. Is there a swelling component? Is there an inflammatory component? Is there a loading component? Is there a psychology component? Because we all know that, you know, if you've got stresses of any type, that's going to exacerbate symptoms. Are they a floppy person? Are they a stiff person? What age group they are? So you look at all those different boxes, tick which ones you need to tick, and then prioritise according to what you find your subjective and objective assessment. So yeah, you need to consider all that stuff. Absolutely.
That's really interesting. I remember that sheet in the order of the initial consultation form is really helpful. So, in your clinical presentation, where do you see that posture and its relation to movement really plays a role?
Well, if I get just probably to the topic that I wanted to discuss, we can sort of extrapolate from there.
Yeah.
So, do you want me to jump into that?
Yeah, jump into that.
Well, overall with posture, I mean, we don't even know what posture is, right? Have you seen a book on posture?
Not any good ones.
No. So no one of any credibility is willing to write one because we don't even know what it really is. And there's crazy debates over what posture is, and you get a lot of people at the moment saying that posture doesn't cause pain. I mean, that's ridiculous. It's ridiculous to say that posture causes pain and posture doesn't cause pain. We just don't know. We have to go case study by case study. I guarantee you, if I get you to sit in the biggest posterior tilt you possibly can, with a massive extension of your mid-cervical spine, which is a posture, how long do you reckon you'll last for? Some people might last for an hour. Some people might last for like 2 minutes. I'd be like that. My head would fall off. So it's the debate over posture is an ongoing one, but I think posture is incredibly important to consider. There's no such thing as an ideal posture. I just think there's different postures. And if I'm giving someone advice on posture, I'll say create 5 or 6 different postures to be in any given hour. So you're constantly loading different structures. Probably my most go-to postural advice is if you had a hook through the top of your head and you were elevated towards the ceiling, towards the sky, that elongates your spine. I think that to me is probably the best postural position to accommodate gravity for the spine. I mean, that's a half an hour talk right there, really, if I explain that a little bit more. But if you're sitting down, put your finger on the top of your head and you lift towards the ceiling and let everything else relax, the amount of weight that's then borne through your hips rather than your spine is quite considerable. And you only have to stand behind someone and push on their shoulders in what we call a pull posture, this sort of slump posture, and they'll collapse all over the place, and a lot of times it reproduces their pain. So they'll go, oh wow, that really created my pain. And you get them up in this position, let their shoulders relax, press down on their shoulders again. I mean, you've seen me do this 100 times, right? Yeah. And that person goes, wow, I can't feel anything. I feel as strong as an ox. So I think that is probably the number one for me. And everyone that you do that to, they'll accommodate a different position. So that would be potentially their ideal posture, and everyone's ideal posture is going to be different. So I think fundamentally that's the way I go about it. I don't think that posture, to me posture is very important, but there's no such thing as an ideal posture. You just have to adjust their posture according to what they present with on any given day. And you'd have to go over dozens of case studies to actually see where posture is important from one person to the next. So for those people who are saying that posture is not important, I just think that's throwing the baby out of the bathwater. I think it's ridiculous. But you can't really put this is the perfect posture to anyone. You really have to go over case studies, and I think that's fascinating. I love doing case studies on those sort of people. And as I said, I'll present stuff I'll present today, and you'll start to see where, wow, you've got the fundamental postural considerations, and then you've got your different planes of posture, whether the old classic let's slump into a posture, and then you've got again what I'm presenting today is some of the normal asymmetries of a spine and how important they are to consider when you're looking at someone's posture.
Yeah, well, I think there's some really key messages there. Is that cue is a nice one. It's easy to understand from a patient point of view, but I also really like how you said there's 5 different postures that you could sit in throughout the day, because any one posture that we stay for too long, whether that's sitting, standing, whatever that may be, that's a long period of time. So if we're adaptable to different positions, that's going to evenly load different tissues throughout the body. So some really great takeaways there.
Yeah, I think that's the most important part. Find the posture that, and again, it's intuitive process within the clinic. What's the best posture for that person? I'm 6'2", skinny and hypermobile. So I struggle with postures because I can't hold myself up. Where, one of my colleagues, Jimmy Barker, so Jimmy's 4'3". No, he's 5'3". He's super stiff and you can't bend the bloke. So he doesn't struggle as much as what I do. So everyone's going to be considerably different. For me, I've got a number of different postures. I sit or stand in any given day. So as you said, I load different tissues. If I sit in the one position for half an hour, I'm gone. But that's different to the next person that can, because they might be a stiff person or whatever the case may be. So you've got to come up with a number of different postures to constantly load different tissues.
I completely agree. Okay, well, let's get into the normal asymmetries, if you will, that you'll see that you mentioned before.
So this started many years ago, travelling with sport. So I was travelling with a few different sports, but then mainly with triathlon. And with those guys, you're more or less assessing them every day. Those guys, they're so injured all the time. So you're constantly looking at, for each individual, what their necessary range of motion is to keep them injury-free. And everyone's going to be different. And it's a bloody luxury to have that experience. When you can assess someone once or twice a day for 2 straight months, you really get to know someone's body better than what they do. So it's one of those things that I'm blessed to have in my career, and I've learned so much from it. What I did, I started to notice a lot of things within the triathletes, and they were patterns. And I hate patterns because they make you lazy. You start looking for them, but they were too profound not to dismiss. And I won't go through all of them, but the one that I was really interested in was I was seeing a whole lot of triathletes, and then back home in the clinic, that had a rotation to the right of their mid to lower thoracic spine. And it was so prevalent. And initially I thought, why are they erectors bigger on the right to the left? But then it looked closer. It wasn't their erectors, just the fact that their spine looked rotated. So I was asking quite a few other people. My sister's an osteo, and we talked about it quite a bit. And she said, yeah, I'm seeing the same bloody thing in the clinic. Why? So we started to look for some research, and it was very hard to find. But and look, honestly, I thought maybe I'm just looking for this and it's just all bullshit. It's just me looking for it. I'm looking for confirmation bias. But then one of my colleagues said, hey, Brad, check out this scoliosis paper. I looked through it and went, check this out. So it was a fascinating study, and it came about where a group of people looking at scoliosis looked at 5,000. Look, I might get some of these details wrong, so don't kill me. 5,000 x-rays of people who had tuberculosis. So I looked over these x-rays because they were looking at why is there a particular scoliosis that's occurring very regularly to one side. And that's where all the information started to come flooding through. And again, I wish I had this years and years ago. So what they found over those 5,000 x-rays is that from T6 to T11, and the apex is somewhere within that region, that there is a rotation to the right of 5 degrees plus or minus 3. And that's with 95% accuracy. So that was extraordinary finding. So 5,000 x-rays, and of those, 5 degrees plus or minus 3. So it could be 8 degrees rotated to the right from T6 to T11. That's quite a bit.
Yeah.
So straight away I thought, wow, there it is. See, I'm not cross-eyed. I'm not searching for this. It's actually there. So then started to do some more reading, think, well, why is this occurring? Because you could just imagine straight away the clinical implications to that. is that straight away when you're looking at rotation of the mid to the lower thoracic spine, you have to now consider that to be normal. If someone rotates to the right more than the left, that's not abnormal, that's normal. So that was massive for me, massive. Because when you're talking about swimming, running, cycling, all different types of sport, you think of tennis, for an example. If you're a right-hander, when you're serving, you have to have a lot of rotation to your right when you serve through your thoracic spine, right? What happens with your left-hander? So you are now fighting against your own natural rotation. Think about a golfer. If you're a right-handed golfer, your backswing, you have to rotate to the right, so you've got good rotation. But when you follow through and you need to rotate to the left, you haven't got that left rotation. So hence you can have all sorts of issues with your golf swing. And of course, there are a couple of different sports, but then just think about who's someone, excuse me, Brad, got a few midges in. Yeah. I'm in Canberra, why is there midges? It's getting hot here. So you think about someone who's just sitting at a desk and they've got an 8-degree rotation to the right of their mid to lower thoracic spine, and they've got their back up against a symmetrical chair. So what's going to happen? So you start to see how this normal asymmetry of rotation of your mid to lower thoracic spine can have all sorts of implications to sport and sitting and postures and so on. So I thought, well, why does this occur? And of course, the obvious things pop up. Oh, it's right-handedness. But they looked at that. So they looked at all the different people, about 12 to 14% of people in society are left-handed. When they had a look at all those people, no, they were all still rotated to the right. So you count that out. Then they thought, well, hold on a sec. This is a really interesting study, is that some people have inverse organs. So like twins, for instance, right? So you can have twins with organs one way and one with inverse the other way. It's the heart sitting on the right, liver sitting on the right, and so on. When they looked at that, they found that the rotation actually went to the left. So of course you start thinking about, well, this is a developmental thing. It's some type of rotation according to our not embryonic growth, just our growth through adolescence. Yeah. That led them to look at, say, spines that were about 7 years old. So up until about 7, we're actually symmetrical, relatively symmetrical spine. But then at about 7, standard deviation a couple of years, I guess, when our organs really start to grow, so our liver sits on the right and heart to the left and so on, that's when we start to see that this spinal rotation start to occur at about that 7 or 8 years old, right? It should stop at about 13, 14 for girls and a little bit later for boys. Boys develop a little bit later. And it usually does. But in this paper with scoliosis, sometimes it continues to occur, and we talk about that in a minute. So hence it looks like what happens is our organs grow, and then our spine then accommodates that space by creating rotation to that side to create more space. That's the common theme at the moment. So that's potentially why we have this rotation. I'm not going to talk about this a lot today, but our upper thoracic spine actually have a rotation to the left of 3 degrees plus or minus 2. Right?
Yeah.
So if we've got these, it's a little bit tough. Like, sort of need this three. I need to have a bloody skeleton and so on. But if you can imagine, so our upper thoracic spine is rotated to my left 3 degrees plus or minus 2. All right. So hence the ribs on that side will seem more pronounced. Okay, we might go, wow, this is an asymmetry. I need to get them rotating back, but that's their normal anatomical position.
So I think that really interesting when put yourself in the shoes of a student going through college or a fresh graduate, and they're taught postural symmetries that shoulders need to be in alignment and pelvis needs to be in perfect position and so on. When it's interesting to understand, we've got these normal changes through normal growth and development that will see us having a rotation of the spine. It will see one shoulder sitting higher or lower than the other. So that's really interesting to understand that they are normal. We don't necessarily need to correct them back to a textbook alignment as such, but it could certainly play a role in if they're loading it adversely.
Absolutely, and that's that's the part that it's clinically really important to understand, and it's a difficult topic to talk about because it's case study by case study. There's no real one rule which you can apply to each and every case. Before we get onto that, can I just continue the anatomy part of it?
Yeah.
So haven't quite finished there. So really interesting with that rotation in the thoracic spine down the right. And again, it's that 5 degrees plus or minus 3, T6 and T11, is that the paper was a scoliosis paper, and so they're a little bit more focused on the scoliosis part rather than the anatomical part. So what they thought was, why is it that some people, their scoliosis so scoliosis by definition is 10 degrees rotation, and it's arbitrary. Because I asked that question all over the world, why 10, why 10? And they said, because
needed a number.
They needed a number. So they said anything beyond 10 degrees and we're going to consider it potentially abnormal. So what they found was, you've got these normal rotations, but then if you created axial load and dorsal load, as in flexion, then the spine would actually rotate more, right? So you've got a 13-year-old kid that's got 7 or 8 degrees rotation to the right, and then happens to sit in a really poor posture for a prolonged period of time, that the evidence shows that they'll actually rotate more to that right-hand side and potentially drive themselves into a true scoliosis. So that was really interesting. I read that. So hence, how important is posture during that period? It's incredibly important. This is what this paper is suggesting. So for the kids that have that greater rotation through that portion of the spine, then wow, maybe we should really emphasize how important it is for those kids, and good luck with a 13-year-old.
Yeah, it's
I know you haven't got kids, but I've got 3 of the buggers trying to get them to it. It's almost impossible. But if they are sitting for a prolonged period of times in that flex position, then the evidence is showing that they could potentially end up with a true scoliosis. So I think that's a really important take-home message. So it's that axial load with dorsal load, so flexion. So I think that part was really important. I've written a couple of little notes here for myself. I generally just do that off the top of my head, but I thought I'd no, that's about it. So if you want to get into the clinical part, so the anatomical part, that's it. That's the extent of it. As I said, I'm not talking about the upper thoracic spine today, but just that in itself becomes so important. How it extrapolates up and down the spine, it creates all sorts of other asymmetries, which we look at and think, why do I see that all the time? And then it starts to become obvious. Well, it's normal. That's the way we are. If we went down into the lumbar spine and sacrum, bulk of people tend to sit left on left with a right anterior rotation, slight inflare. I mean, you always see people that ruin that rule for you. But it's the general consensus is that that's what you see all the time. But then you look and think, well, it's obvious because that's the normal rotation. So how much do I need to correct that? Right?
Yeah.
So when we go up the spine, and you look and think, well, you've got that left rotation of the upper thoracic spine. When you've got that, I mean, if we were all just stayed there at 5 degrees pointing to the left, the well's not there, it's over there, so I'm going to bring my head back. So then you've got your rotation of your right through your C6, C7, T1, right? So you have a look, and a lot of studies show that right rotation of the lower cervical spine is normally about 7 degrees. So we're basically all sitting here doing it. Right, but we don't put the computer over there because we need to stay 99. So you think, well, hence most people rotate more to the right than they can to the left, right? Yeah. And again, clinically over the last sort of 7 or 8 years, I've just looked at this over and over and over again. Why are you checking my neck? It's my foot. Yeah, it's all connected, mate. So I'm just trying to look at it all the time to see what everyone presents with. And if you put your hands either side of the C7 and T1 and get them to rotate one way and rotate the other way, and just follow how much that spinous process moves with that rotation. I can't say guaranteed because I'll always get that one bloody wrong. But if you watch, I'll say that the bulk of people, one will rotate more to the right and less to the left. But you'll notice that C7 T1 will actually move with the rotation to the right, but not so much to the left. Right? And I've seen this over and over and over again. So if that's normal, then what type of pathologies can that set up where we miss 90-90 well? So you have to look to the left all the time, and your C6, C7, T1 are not helping out. Where are we going to get it from? So we generally get it from that C3, C4. It can only rotate so much, and you'll see a crease line on some people's neck on the left-hand side, right at that C3, 4. So they'll rotate, that's it, got nothing else, so you can't rotate your side bend. If you rotate and side bend a facet joint over and over and over and over and over again, what happens to it? You get degeneration of C3, 4. That, I'm talking to a couple of radiologists in town, and they're saying that is by far the most injected cervical facet joint, C3, 4, on the left-hand side. No, on the right, on the left. So I know I'm reaching here, but you look and think, well, is that the case? Is that, we're trying to look to the left. We don't have that rotation normally. Got plenty to the right. So when you're looking at those people, we think, well, C3, 4 facet joint degeneration, left-hand side, is it because they have a more than average rotation to the right of their lower thoracic spine than the average Joe? Okay? So then it becomes the really interesting part, is that if that's the normal static positioning of a spine, do we just accept that and don't try to change it? And that's the debate, right? That's what everyone's saying. It's normal, just leave it alone. If we did that, we wouldn't bloody do anything. We just go, it's normal, mate, sorry. Away you go to the next practitioner. So it's more, to me, not just the static positioning, because you can have a C7 T1, let's say 7 degrees facing the right. But to me, if I consider that anatomically normal, but what is the movement? Because they should be able to still move the same both ways. Right? We still look to the right, we still look to the left. So often with those ones, this is what I've seen, and I can't explain why, is I'll often have a look and see how much they're moving. So let's say, for argument's sake, 30 degrees of rotation of the lower cervical spine to the right. Yep. And then you go to the left and it's not moving at all. So if it's not moving at all to the left, you think, well, that's not moving. Then all the movement therefore has to come from other segments. So it's the other segments that will end up being the ones that are compensating and therefore become degenerative, like the C3, 4 example. So to me, although that's a normal static anatomy, it's not a normal dynamic anatomy. That anatomy should still be able to move. And with the lower thoracic spine with the rotation to the right, you'd expect them to have more rotations to the right because they're already facing that way. But you should still be able to rotate to the left. Yep. So the acceptance of the static anatomy, yeah, I agree with that. But I'm not going to sit there and accept the fact that the dynamic portion of that shouldn't be there. We still should have range of motion. And that's the thing that I've applied clinically. And it sounds so arrogant, but it's been good results.
Yeah. And I think that's a key point there as well, is that we look statically, but we need to look at their function. How well are they functioning, and then sort of marrying those up, how well does that fit together? Because at the end of the day, we're trying to improve their function and their movement to decrease their symptoms, not necessarily saying that you've got these structural changes or malalignments. It's how well do you move?
Absolutely, mate. And that's where I've completely changed my narrative. I mean, we all do, or we all should, as we learn more. And I'll tell people, look, this is normal. So if someone tells you this is not, then run. So this is normal, but we should be able to get better movement in this direction. And look, what's so fascinating, talk about the knee bones connected to the thigh bone. If I've got someone that can't rotate to the left very well through their cervical spine, and it's super irritable, so you don't want to really go to that spot because you're just going to further irritate it, right? Yeah. So you look down their spine, you think, wow, look at that rotation to the right in the lower thoracic spine. So treat. Yep, that's now moving better. Now move your head to the left. Now I guarantee you, 9 out of 10 times they go, how the hell does that work? How does that... So, you have to pull a rabbit out of the hat and basically tell a porky, because how does that work? We really don't know. So I often find that if you get reasonably good movement somewhere in the spine, then the rest of the spine will start to accommodate movement as well. And you have to talk to someone else about that one.
So if we're talking about that sort of that C7 T1 rotation, how would you look at treating it? What are some sort of techniques or treatment interventions that you would look at applying?
Really good question. So the over the years, what I've done is I generally go to the lower thoracic spine first. And the reason I say that is I've tried thousands of times thinking, what is the primary factor here? You know, like we were talking about the boxes before, you create all these boxes for a patient, you tick the ones that you think are important, then you've got to prioritise which one you think needs to be treated first. So you look and think, wow, this is so inflammatory, I shouldn't do anything today. Send them home, tell them to go to the chemist, get some anti-inflammatories, come back in 5 or 6 days time when the inflammatory components calm down, then we'll deal with the next component. So I look at like that, the spine, thinking, well, what is the most primary here? So I've tried a lot of different sequences. I hate sequences, but thinking, well, I'm going to leave that cervical spine alone and just treat this lower thoracic spine. And I've found, to me, that gives me the greatest results. I don't know why, don't understand it really, but I found if I get that moving, that thoracolumbar spine moving to the left well, then the stuff up and around the neck decreases quite significantly. And then what's left over, I'll treat that. Mm-hmm. Right? So when I say I tweak that C6, C7, T1, you can use whatever trick you have in your tool bag, mate, really. I probably have an osteopathic sister. I probably cheat a little bit and use a lot of her techniques. And look, by the time you're my age, mate, 106 years old, you can't tell the difference between one therapist to the next. And you don't give a rat's backside what's on the wall anymore. You just treat people like good practitioners rather than an osteo or a chiro or a physio web. So I'd probably use a few more techniques where I'm trying to get like a thumb on the C7, and as they're rotating to the left, I'm encouraging it to go with that movement.
Mm-hmm. So like an active mobilization technique.
Exactly.
Yeah.
Yeah. Depending on what profession you are, you'll call it something different.
Mm-hmm.
So it's basically got your hand on that C7 as it goes. You're trying to encourage it to go further to the left.
Yeah.
Just to R1, just beyond R1. You don't want to go overboard, because if someone hasn't rotated to the left for a long period of time, or we'll go away, Midgie. If someone doesn't go to the left for a long period of time, you've had a joint that moves into a particular position for a long period of time, you know what it's going to do. It's going to get the shits.
Yeah.
If it's a 16-year-old, then go for it. But if it's a bloke like me, be careful. You'll break me. So you've got to, again, use your intuition of how aggressive you want to be with those techniques. A lot of times you might think, well, hold on, I've got so much myofascial stiffness here that's built up over decades. Do you treat that stuff first? And really, I don't really have a care of what technique it is. It can be cupping, soft tissue work, myofascial work, dry needling, whatever it is, as long as you know what we're trying to achieve.
Yeah.
If you've got some connective tissue stiffness, then use techniques you know is going to mobilise that tissue. If you've got some spasm or triggers, then use some dry needling or some basic trigger point work. I think, to me, I'm not really a technique person. I'm more of a I know what I'm trying to achieve, what techniques we've got to get there type person.
Yeah.
So I might go a whole day when I don't use dry needling at all. And then next day I might use it quite a bit because I see the need for it. So whenever it's indicated. So that whatever technique it is to get that complex moving better to the left. And sometimes it's mobilization of the first rib on the left. Because if you've got a rotation to the right, remember the coupling, if you rotate to the right, you side bend to the right, yeah? Which means that your left hand first rib, if the T1's rotating to the right, side bending to the right, your left hand first rib is going to be high. Yep. So often when you sit there and have a look at the two from behind, you've got this rather big discrepancy. So again, you can't change that first rib. You can't just push it and poke it and play with scalings and expect it to drop when you've got that T1 sitting to the right. It's not going to happen. So you need to get that T1 mobilised to the left to get that first rib to drop down.
And what's great here is you've got this three-dimensional view of anatomy in your head, and I think that's a huge takeaway of a lot of clinicians and therapists that are learning is try to understand that anatomy to a greater detail, because as you've said there, Brad, is that you might have your pain at C7T1, but you might be treating that lower thoracic spine to get that change, because in that acute presentation you go poke and prod C7T1 and it makes them worse. We need to understand, well, how can we get that change by treating more around that area, more distally from that side of pain.
I always call it direct and indirect treatment. I mean that's just I'm just hopeless at remembering other people's terms, so I just create my own.
Yeah.
But to me, direct treatment, if you want to just focus on a levator scapula, use some whatever techniques you like, cupping, needling, just manual therapy work, then go for it. But understand why you're doing it. What are you trying to achieve? Then you think, well, it is so hot, it's so irritable, I'm just going to piss this thing off. Then what else can I do? That's when you got the indirect treatment. Well, why is that levator scap so angry? What's happened? Is there something else I can change somewhere else to reduce its load? So the way I work is I reduce the load first, and whatever's left over I'll treat directly. Yeah. And when I was a kid, I did the complete opposite thing. Levator scap's really cranky, so I treat a levator scap. I knew everything. Don't tell me what to do. I don't know what I'm doing. And then as you get older, you think, oh God, I have to ring people like, oh no, I'm sorry. I know this about you 25 years. I was wrong. I was there. So to me, I always treat the indirect stuff first, the stuff away from the site, and then only go there if I need to. So, as you get older and hopefully better, some of the indirect treatment you do will completely get rid of the person's presenting pain dysfunction. So if you get a C3-4 and they can't rotate to the left, treat the thoracic spine, treat the lower cervical spine, and then they'll rotate going, oh wow, it's gone. It's not gone. The irritation's still there, just you've taken the load off it. So I think that's, again, it's so important to understand, the classic old trigger point stuff when people say, oh, this person come to me and I fixed it because it was their TFL. And I needed the TFL and I fixed it, so the problem was their TFL. Well, the problem wasn't their TFL. The TFL doesn't wake up one morning and go, oh, I'm going to be cranky. Just because I'm just going to be cranky. Why is TFL cranky? That's where your history, subjective assessment, creating all those boxes for yourself, trying to figure out why is the TFL so cranky. Now, if you want to treat the TFL to rid the referral and tension on the tensor fascial artery and something, yeah, go for it. But you've got to also treat the reason behind that trigger point development in the first place. And again, with this, what we're talking about with the spine, absolutely, you've got to do that. And this is where understanding what the normal anatomy is and how you can change things well away from the side to give you good change gives you enormous amounts of treatment options. And I'd suggest better treatment options, because when you do go to the side of discomfort, you're more likely to make it angry than to make it better. The classic example being a torticollis. Someone turns up, can't rotate, oh, it's really sore here, so you bash at that spot, put some heat on it, and they go, oh, that smiles better. And 20 minutes later, they want to kill you because they've gone out, calmed down, you've irritated and inflamed the area even more. So again, having that understanding of that normal anatomy, getting things moved well away from the site, so that site doesn't get it as loaded, that's incredibly important.
That's fantastic, Brad. And I've had so many of those penny drop moments over the years that a lot that I've learnt from you as well. Really understand, well, why is it like that? Why is that muscle cranky? Because it doesn't just get cranky for no reason. So that's where the assessment really plays a huge role. And, assessing, treating, reassessing throughout the session, I think that's key. Because like you said, you go in and press on that angry facet joint, and more pain equals more pain. So that may not get the therapeutic effect that we're chasing.
Yeah, and as well, it's really important to, again, have a star sign and a clinical sign. So the star sign to me is someone comes in and says, I can't do this. So that's their star sign. That's what they want you to change. Then you look at your objective test and you see some clinical signs which you want to change, right? If you change them, and you go, yeah, I've changed them, and it doesn't change their star sign, then you've missed the boat. So having those different assessment outcomes, you've got to make sure it marries up to what the person wants out of the session. I used to do that when I was younger. Yeah, I've really done what I wanted to achieve. I achieved nothing for the patient. They walked out feeling the same. I wrote down my notes, cured them, legend. And of course, they didn't turn up next week. I wonder why. So you've got to really try to match what they're after, and it's just so important to do so.
Definitely. Brad, I think we'll wrap it up there. That was fantastic. I think there's so much to take away from that. So thank you so much for joining us today.
Thank you, Bo. A few people might actually listen to this because a lot of people have got nothing to do. Except crazy bigs on, mate.
Looks great. Cheers.
All right.